Hi everyone, good evening, good afternoon, wherever you are in the world. We are about to be joined by Dr. Gad Lavy, and we're going to talk about recurrent miscarriage to honour Baby Loss Awareness Month in the States and Baby Loss Awareness Week, which we currently have in the UK right now. So everyone have questions ready for Dr. Lavy. We're going to be talking recurrent miscarriage and things that you can do treatment-wise to support facing such a challenge. So welcome. Hi everyone who's joining. Good evening, good afternoon, Dr. Lavy. How are you?
Hi, good evening. Good, thank you. Thank you for having me.
Of course, it's lovely to be joined by you. For giving us your time. I've just introduced the topic today. I'm sure it will resonate with many who are joining and watching. It is, of course, Baby Loss Awareness Week here in the UK and month internationally. And so we're going to talk tonight about recurrent loss. So first of all, please could you explain a little bit about what recurrent miscarriage means?
Sure. So, unfortunately, many pregnancies end up in a loss. And basically, the pregnancy loss is defined as someone who becomes pregnant, and at some point, the pregnancy doesn't thrive, doesn't continue. It can happen really early, even, right around the time that the woman expects her menses. Can happen early in the first trimester, and it can even happen in the second trimester. So we basically are looking for clues, and sometimes actually when the loss happened gives us a little bit of a better indication of what's involved, what is the reason.
And so for people who are facing this challenge, what point of their journey do they normally come to you? Is it people who may have had loss from having conceived naturally through treatment? What are the different
Well, people come from different places. So, it's really hard to get a good definition of what is a recurrent pregnancy loss. Someone who experiences one loss is probably just bad luck, a fluke. There's studies that show that in those cases, actually, the chance of having another loss is no different than it is in the general population. So if you look in the literature, the recurrent pregnancy loss is defined as having 3 consecutive losses. Now, of course, it's easy to write it down in a textbook, but it's hard if you're that person not to start worrying, because even having 1 is devastating, let alone having 2 and having to wait to see if the 3rd one will be successful. So I think people have a different threshold to when to seek help. And, of course, we're talking about medical help, and not quite as important is the emotional support in the process.
Yeah. And so when would you advise people to seek help?
Well, again, it depends on a variety of factors. I think probably most important is the age of the woman. Because women who are young, we assume that they have still plenty of time to become pregnant again. So if they're not particularly stressed, maybe they can just try again, and hopefully the second one, as I said, is a good chance of being a normal pregnancy. Women who are older, 39, 40, 41, in those cases, actually, your window of opportunity of the reproductive window is starting to close, and each loss can put you back, a good few months. So if you have a loss, God forbid, can, basically it could be maybe 4 to 6 months before you can try again. So in those cases, I think the threshold should be lower. Of course, there are cases where there is some underlying medical condition, things that, so in those cases, it's probably a good idea to check early. My opinion on basically when to seek help, when to ask the doctor, is it can't hurt to ask sooner rather than later. And, in some cases, I just spoke to a couple yesterday, they've been trying for 6 months, and she conceived within 2 months and had an early loss. So she was very worried, and I basically explained to her that this is common and probably doesn't mean anything. She was 35, and I offered them to do an evaluation just to try and find the reason. But more than that, I just suggested maybe they can go back and try, because once you start getting into the system, so to speak, the medical system, you know, it definitely increases your stress level.
Yeah, I agree with that. And obviously everyone wants to know the answer to this, but why do miscarriages normally occur?
Well, I would say that the vast majority of miscarriages happen because the embryo is not genetically normal. So there's some genetic mismatch, and apparently it's a very common occurrence. And interestingly, it's much more common in humans than it is in other species.
Really?
So that's, I would say, the most likely cause. And in fact, you know, there were studies that were done on basically on general population, people who are not even trying to get pregnant. And they did a very early pregnancy test, even before the expected menses. And they found that many women were pregnant briefly before they even missed their period. And again, if the embryo, and we learned a lot about this from IVF, because what we see that basically the embryos that are viable, capable, are the ones that are genetically normal. So number one, I would say is probably over 50% of the cases, it's related to genetics. Mm-hmm. There are some other causes. For example, there are causes that have to do with structure of the uterus. So it could be the embryo, or it could be the uterus. So any kind of structural abnormality of the uterus, fibroid tumors, polyps, things like that, can definitely cause recurrent losses. And then these are, I would say, the two most common causes. And then you're dealing with things that are much less common. And somehow we sort of tend to focus on these things, right? People talk about a hormone imbalance, which can happen, but is not very common. The hormone levels are not high enough. The progesterone is not high enough. That's definitely not a common cause. And then there's the real sort of rare conditions, immune condition. There's women that have autoimmune conditions. Women have an abnormal clotting system that deprives the pregnancy from nutrients from blood. And, you know, of course, we always look at those things because we can test for them, even though we know that it's highly unlikely to be the reason. Okay. And, of course, at the end, after all is said and done, and then someone goes through, you know, an extensive evaluation, there are some cases that are not explicable. And so those cases are probably the most difficult, most frustrating.
So someone has just asked that point. Is an ultrasound and a sonograph?
Excuse me, I'm sorry. You're breaking up. Can you ask again?
How do you know if there is a problem with the uterus? Is an ultrasound enough to detect that?
Yes. So there's a whole list or sort of a panel of testing that we do for women with recurrent loss. And one of that is to check the uterus, the structure of the uterus. And that involves usually doing an ultrasound. It's a special type of ultrasound. It involves infusing a little bit of fluid, a little bit of saline, and that actually opens up the uterine cavity and allows you to actually look at the walls in great detail.
Mm-hmm. Am I right in thinking or hearing that pregnancy tests are much more advanced these days, so they pick up chemical pregnancies?
Yes.
And detect things that we may not have been aware of years ago. And so people may have knowledge of miscarriages that they wouldn't have historically known about, that they were pregnant.
Absolutely. This is the study that I mentioned. This is a very old study when the pregnancy tests were not that accurate. Mm-hmm. But that study actually did a blood test in the very, you know, maybe a week before the expected period, in women who basically were not even trying to get pregnant. And it found that there was a significant number of women who are pregnant and don't know it because they get their period. And you're right. You're absolutely right. That, you know, having a very sensitive home test is sort of a two-edged sword in a way, because it allows you to sort of identify those pregnancies that are not really meant to happen.
Yeah. And so for people who are facing current loss, what are treatment options that you provide at the Fertility Institute? What can people look to you?
So I think, in general, and this is true not just for pregnancy loss, I think it's really, really important to take some time and make a little bit of an effort to try to understand the reason. Because if you do, then it's a lot easier to figure out what to do.
Mm-hmm.
So, for example, I'll give you a few examples of genetic losses, right? So there are some genetic losses that happen because one of the partners carries a certain abnormalities in their chromosome. So not all the children will be affected, but those children who are affected, or these embryos will be affected, will miscarry. So that's one example. This is when one of the partners is a carrier. Another example is women who are older and their egg quality declines. Those women have a higher incidence, a higher likelihood of what's called aneuploidy, when the chromosomes are mismatched. So again, that's probably the most common cause of pregnancy loss especially in older women. For that, the treatment is usually IVF. Mm-hmm. Because IVF allows you actually to assess the embryo, examine, test the embryo before you put it into the uterus. So allows you to identify those embryos that are normal. And if there are no normal embryos, then you know, and you don't do the transfer.
So do you test frequently with patients, or is that more for people who may have had loss, for example?
Well, there's definitely different opinions on genetic testing of embryos. I actually personally am a big believer in that, and we do the genetic testing routinely on all our IVF cases. And interestingly, and the reason the more we do, the more I think it's helpful, is that it's not surprising that if you take a 42-year-old woman and do IVF and test her embryos, basically 90% or more of her embryos are abnormal. Mm-hmm. So that's not surprising, and we've known that, and that's why it's so difficult to get pregnant. But we also work with young women, specifically with egg donors. These are women who actually donate their eggs. And those women actually are chosen for their fertility. They're young, they're healthy, they have normal blood work. And when you do genetic testing on these women, you find that even there's about 30 or 40% of them that have abnormal embryos. So it's a very common problem. It's a common issue. I think, again, it's a naturally, and for some reason that we don't understand, it's much higher in humans than it is in other species. But again, as far as trying to get around this genetic issue, IVF is sort of probably the quickest and best way to do that.
Mm-hmm. We've had a few people comment on the same thing, actually, which is, I know, a controversial topic, but elevated natural killer cells. What are your thoughts on that?
Well, as I said, that sort of falls into that category that I said, we all think about, we talk about, but I think it's unusual for that to be the reason. And, sometimes we sort of tend to focus on that because we don't really have anything else. And, the data to support that is not very good. So yes, there are cases, there is an increase in natural killer cells. And then if you address that and you treat that, you can prevent the losses. But I think it's sort of it's overrated, in my opinion, as a cause.
Mm. And people have asked about here as well.
I'm sorry?
People have asked about steroids here as well, which
steroids?
Steroids, sorry.
Oh, steroids.
Yeah, which I guess goes hand with that.
For treatment?
Well, using steroids, I guess, to suppress natural killer cells.
Oh, I'm sorry, yes. I'm sorry, you're breaking up a little bit. So, yes, if that is diagnosed, so there's different treatment modalities. I mean, steroids is one of them. There's a treatment called IVIG. It's basically infusion of immunoglobulins. That's sort of a big deal, but it seems to work for people who have it. There's another modality where they infuse what's called intralipids. That's sort of a intravenous supplement, a nutritional supplement. So there's different types of treatment. People use aspirin, people use other things, depending on the issue. But again, like I said, I mean, it's really, really critical to identify the problem and not just randomly treat, because some of these treatments are not benign, right? So the IVIG treatment, for example, even the steroids can have side effects and complications.
Absolutely. And they can be expensive as well, adding on these extra things.
Of course, yes. Yes.
Someone has just asked, you mentioned genetic testing. Do you prefer, well, I know you mentioned this earlier, but to answer their question, you prefer to do it across the board for every patient you see, doesn't matter about age. Is that right?
Yes, I do. And actually, we do the genetic testing for the couples before they, as part of their diagnostic testing. So just to make sure that their chromosomes are balanced, because like I said, sometimes one of the partners carries some kind of a chromosome abnormality. We also do what we call a carrier screening, looking for recessive genes, because that also can be a cause. So yeah, we do a genetic testing prior as part of the diagnostic workup, and then we do it during the IVF. And yes, I do think that everyone who does IVF should have it done.
And for people who are using an egg donor, you mentioned egg donation earlier. Does that
Yes.
have a lower chance of miscarriage than people using their own eggs?
Of course. So, you know, again, like I said, the miscarriages often happens because the chromosomes are not balanced, and that's much more common in older women. Now, going back to the genetic testing of the embryos, so if you do genetic testing of embryos, and you pick a genetically normal embryo, then it doesn't really matter where that embryo came from. If it came from a 25-year-old, from a 35-year-old, or from a 45-year-old, the chances of that embryo having a successful outcome are the same. So the chance of success are higher, the risk of miscarriage is lower. Of course, the challenge in the older woman is there's less of a chance of actually being able to create those normal embryos.
Mm-hmm. And for embryos that you've screened with testing, and then they go on to implant, but then they miscarry, what can you learn from that?
Well, of course, what I can tell you, is if you take a genetically normal embryo and the uterus is normal, then you expect close to 80% success. So wow. Yes, so it's not 100%. So where are those 20%? And the truth is, we don't really know. There's always a possibility that the uterus is not as normal, as receptive as we think it is. And clearly there's more to the competence or the viability of the embryos than just the genetic testing.
Yeah, of course. Thank you so much for that. I've had someone question. They've had chronic endometritis, low progesterone.
Endometritis. Yes.
Yeah, low progesterone during pregnancy and high natural killer cells. They've been on Clexane, which is in British, Lubion, is that how you say it? And
intralipid,
etc., and they still have miscarried. What would you say for someone in that situation where they've tried multiple things? I know it's obviously case dependent and
right. It's a little hard to give advice like that, but again, I would if you think you've identified the problem and you do whatever you do to fix it, and it doesn't work, I think you have to look back and say maybe what you think is the problem is not really the problem. And again, it depends on the case. It depends what you try afterwards, how many times. But what I find is sometimes, people focus, an example on high natural killer cells and do all these treatments, the anticoagulants and the intralipids and the prednisone and everything else. And it doesn't work because that wasn't really the problem. So, again, what this question here is about, it's a combination of different things, right? So endometritis is a whole different category. Endometritis is when there is an infection or inflammation of the lining. And that's something that is treatable with antibiotics. And usually, if that was the problem, then it should work. Endometritis usually does not cause recurrent losses. It's more likely to cause basically infertility, but it can. And the same with low progesterone. Low progesterone, again, is one of those things that I think is overrated as the reason. So, like I said, you need to sort of look back and see maybe the diagnosis wasn't correct.
Mm-hmm. That's brilliant. And last question: does miscarriage run in the family? Is it something that can be genetic for women or for men?
Yes, but not often. Not often. So, as an example, what I mentioned, when there is one of the partners carries some kind of a chromosome abnormality, that is something that can be passed on in the families. There are certain, conditions, medical condition, autoimmune conditions that are genetic. But I'd say that the vast majority of recurrent pregnancy loss are not genetic, do not run in the family. But if you do find, if there's a family history, right, of someone has a loss, and another loss, and her mother had the same story, then you have to look into it. And it's basically sometimes the answer is with the relative or the mother who had it. For example, clotting disorders are a common cause of familial recurrent loss, but they're not common. They're very unusual.
Mm-hmm. I actually had Chicago testing done, and that unraveled a blood clotting issue that I have, which the doctors in the UK told my mother she hadn't passed it down, and she had. So
She had.
She had, yeah, and my sister and my brother also have it. So it was good. It was not something we wanted to have, but it was good to have that information because it just affects other areas as well.
So of course. So when this happens, of course, you use that information and see who else in the family and if possible, avoid this problem before it happens.
Mm-hmm, exactly. Any last words of advice for anyone who's struggling with recurrent loss?
Well, I think maybe the biggest misconception, if I can use that term, with recurrent loss is that once you had one, then you're destined to have more, and that's really not true. In fact, there's a good number of studies that show that even if you've had two miscarriages, early miscarriages, still your chances of having a third are the same as anybody else in the general population. So I think, probably the most important is not to overreact and not to panic.
Okay.
But if you are worried, there is a fairly simple panel of tests that you can have, and just to make sure that you don't have any one of those conditions. I think I don't have an objection to somebody coming in after 3 months and one loss, and they say, well, we need to do a workup because I don't know what's going on. I think sometimes that's worth it because it just puts people's minds at ease.
Definitely, I agree.
And the other thing is that with the technology we have today, I would say that most recurrent losses are treatable.
Mm-hmm.
So and again, it depends on how far you're willing to take the treatment, and if you're willing to take advantage of all the technology that's out there. I think we basically can help most people that have this kind of a history.
Very reassuring to hear. Thank you so much. Thank you, Dr. Lavy, for a great and very, very informative session this evening or today. I know that you've got to see a patient now, but thank you for those who are joining. And if you want to contact New England Fertility Institute and discuss any of this further via a consult, you do offer remote consults as well, don't you, for anyone around the world? Please do get in touch.
We do. So I think you have our email and phone number on your site. I can, yeah. So anyone who has further questions, or as I said, it's very difficult to give advice in a webinar for individual people. But I'm happy to review your case, look at what happened, and give you my opinion.
Fantastic. Thank you. We'll link to all of that here. Thank you everyone for joining, and lovely to speak to you again.
Thank you all for being here, and
thanks
good luck.
a lot. Bye-bye.